This is my client Epi, who I've seen recently, and this is her third visit. And we've treated a couple of patterns in the pelvis, and today it presents anew. And I'll have her describe how she feels.
So, overall, improvements in some areas, and some areas just feel stuck. So improvements certainly in the lower back. My facet joints are not as irritated. In fact, they don't really feel irritated at all. Just something feels stuck in my pelvic girdle, and I, for the life of me, can't tell if it's my sacrum or my ilium or what's going where. So that is why I come to Jerry.
And it feels distinctly to you like it's in the pelvis. It's lower than the lumbar spine.
It's lower than the lumbar spine. In fact, it feels, not even my SI joints, it feels lower than that.
Right. And what are you doing for your lumbar spine?
Some pelvic tilt facet opener type exercises.
Yeah, a little bit of rotation.
Yeah, a little bit of gentle rotation.
Yeah.
Like a little bit of pelvic tuck.
Yep.
The gas pedals.
Yes.
All of
Very
that.
good.
That stuff.
Very good. Alrighty. So,
and the SI belt makes it feel worse.
Interesting.
So I'm locking it down in a way that it doesn't like to be locked down.
So in standing, Epi had some asymmetry of the sacrum. The right lower quadrant was prominent in standing. And I don't trust what I see in standing. It's just one slice, one picture in time. This is a movement-based evaluation and treatment, okay? So it's not based on how things look, it's based on how things move or don't move. Now usually a torsion is most prominent in sitting, and in some individuals you will you will have a normal exam with springing of each sacral quadrant in prone. But when you get them sitting, then the torsion will manifest.
Am I sitting?
No.
Okay.
In this example, no, you're laying down. No, I'm teasing you. I'm teasing you.
I didn't know if you wanted me to sit.
No, I'm giving you a hard time. So, so Epi presents with a torsion, and the nomenclature I use is different than the traditional nomenclature. So here's ILA, she's a little bit lower on the right, and then here's lower sacral quadrant. And I don't think the camera angle is going to see this, but this thumb is higher towards the ceiling, okay? And PSISs are right here, so S1 is here, and she's more symmetrical there, and more symmetrical at S1. I'm sorry, at S2, and then, distinctly, perceivably asymmetrical with this prominent. And now I'm going to do a spring test, and I did this earlier and noted that she didn't have any superior glide on the left side, and also she doesn't have any superior glide on the right side of the sacrum. The spring on the quadrant, so now I'm doing a posterior to anterior, a PA, and you can see the pelvis move. So I can take up the slack in this structure which extends beyond her SI even. I can take up the slack, and then I can spring it, and it bounces and it recoils. When I come over to the right side, I'm using the same amount of force, and there's no movement. I cannot take up the slack. And so at a reasonable amount of force, which is about 15 pounds, I can't take up the slack, and then trying to spring it with another 15 pounds, there's no movement there. And so that's defined as what I name a right lower sacral quadrant, prominent and stuck. To that you could discuss the side bending, but I don't add that complexity, simply because when you treat the prominence, the side bending corrects as well. So in the traditional nomenclature, they would talk about a right oblique axis, and they would call this a right rotation on a right oblique axis. But that nomenclature to me can be a little bit confusing. I wrote a book chapter, 43 pages and 147 references. and that chapter was titled Sacral Torsion, and there's a subtitle that I don't even remember. But basically, one conclusion I make in there is that the nomenclature is confusing, and I've done the research on that when I've taught. And this new nomenclature is a lot clearer. It's a lot simpler because we simply name this right lower sacral quadrant, prominent, and hypomobile. And I think that's a lot easier to visualize and to predict treatment. So treatment is really straightforward. And I like this foam, but you could use a firmly rolled up towel. And what I'm going to do is have her place the foam right above the tailbone so she can feel the coccyx going up the gluteal crease, and then the lower part of the foam is right at the coccyx. Another way of doing that is this is her waist, this is the belt line, and it's the top of this foam is right below the belt line. So I'm going to have you go against the wall, and I'm going to leave the camera here for let me turn the camera.
I'm going against the wall.
Hang on. Just watch me. Okay, just do as I do. Watch me, okay? So you're going to place the foam below the belt line, and that is also above the tailbone.
Okay.
And the flat part goes against the wall.
Okay.
Okay. And then you bring your feet apart, shoulder width, and your heels are comfortably forward 4 to 6 inches.
Okay.
Okay. You lean back and touch the wall with your scapula. And then you bend forward slowly, nose in front of toes. So you're going to do that 10 times. Nose in front of toes. Does that make sense?
Yeah.
And this will be your home program. So you're going to do this once a day.
To above my coccyx.
Yep.
Below.
Yep. Yep, you got it. And then you just bend forward, nose in front of toes. And this causes hip hinging. The movement initiates in the hip and in the lower lumbosacral region. And you're, of course, constantly leaning against that piece of foam.
Oh, maybe I don't.
Yeah, you're always having pressure against it.
That's what I don't have right now.
And don't overthink it. Yeah, just do it. Trust it.
Okay. Doesn't feel like it's doing much.
I think you're overthinking it. Just do it 10 times.
Like it feels like my joints locked down and standing.
All right.
So it's on.
Fair.
So, yeah. All right. I'm just gonna trust the process, and it's sliding.
Okay.
Maybe I need to. There we go.
I could get some super glue.
Now, why wouldn't you do this in lying down?
You could.
Okay.
You
I'm
could.
just curious.
You could. And torsions do accentuate in flexion, regardless of what the traditional literature says. My experience has been that they accentuate in flexion, and in hyperextension they disappear.
Huh.
And this is a different way of testing, but in comparison to the traditional approach. They use kind of gross movement testing.
Right.
And I use the passive spring recoil testing. But yes, you could do it in supine. I would want your hips and knees under several pillows to put you in a little bit of flexion.
I see what you're saying. So it's good to be in. That's why they're out a little bit.
Yeah.
And you're bending forward.
Yeah. But I kind of prefer this technique. Was that 10?
Yeah, it's about 10.
Yeah, so come and lay down.
Okay.
Now no one has done the research. No one has validated that the sacral torsion really is the sacrum twisting inside the ilia. And it's never been studied biomechanically, such as where they insert titanium balls in the sacrum and in the ilium, and then they take imaging of that. That's called stereophotogrammetry. They've done that with other movement patterns, but they have not done that with sacral torsion. It could be more complex than just sacrum twisting inside the ilium. Maybe it's not that. I don't get hung up on that. I know that I, as a clinician, cannot evaluate movement inside the sacroiliac joint. I know that I can evaluate movement external to that. And now you lay much more symmetrical. And I'm going to do the spring test. You'll notice I can now take up the slack. So now I can spring and there's a recoil. I'm still taking up the slack. Spring and recoil. Spring and recoil. I can even see the heel of your foot bounce. So movement is occurring through that. And then the other movement that we found was blocked was side bending, and you're moving very well. I see your head bobbing up and down, and I come over across midline under the right ILA of the sacrum, take up the slack and spring it, and I see the movement traversing all the way through your head. So I'm testing movement going through a structure. I'm not testing motion only limited inside a structure. So this is a more kind of a global perspective. It's more reality-based, accepting what we can and cannot isolate in the clinic. And move around a little bit and see how you feel.
Like off the table? What do you mean?
Any way you want. Any way you can test it and see how it feels, see how it behaves. And while you're testing that, I'll show them my book chapter. So the book chapter on sacral torsion is in this book, Dynamic Body. And I have the book chapter on my website, which is heschinstitute.com, spelled H-E. S like Sam, C-H. And in this book chapter, you can see this guy with black hair, who could only be none other than my evil twin. And it's titled Sacral Torsion About an Oblique Axis, A New Approach to an Old Problem. Barbara Kardakis did the graphics on this book, which are just gorgeous. Absolutely fabulous. Did some nice little pullouts, little things. Torsion can be understood with small change in nomenclature and in the method of screening. Just little tidbits she pulls out. The bony pelvis and the sacroiliac joint are not one and the same, and their distinctions should not be blurred, blah, blah, blah. So I'm very pleased with this chapter, and yes, it really is 43 pages. And I do all that, and I bring it down to a very, very simple nomenclature and very, very simple eval and very simple treatment. So anyway, you can access that again on my website, and there are 147 scientific references. So that's quite a thing to write. So give us some feedback.
Going for a good long walk.
Okay.
I could tell.
Okay.
Getting a lot of getting pain on my ischial tuberosa, whatever attachments are there.
Okay.
Maybe that's because things are moving. I don't know.
Yes. Yes.
You tell me.
Not sure. We'll have to look at it again.
Okay. It still feels a little stuck, but maybe it's because it's been stuck for a month and a half. I don't know.
Okay.
That's what I'm feeling.
Alrighty. So what I'll do is I'll stop filming here and then reevaluate.
Okay.
And it's not uncommon with this model to know that things undergo permutation.
Right,
so,
that's what I'm
so
thinking.
what you start off with, and you know this.
Right, so my homework, it'll eventually get better and better and better, right?
That's my expectation.
Yeah, that's what I'm expecting too.
Yeah, and there might be another movement pattern that's in there that I need to find.
I look at it as an unwinding.
That's right.
Right, so
That's
we were sideswept, now we're
right
here, and things were like, not quite right, so things are, so that's how I look at it.
Right. Last time you had a lower windswept pelvis,
yes.
Correct.
Yeah.
And we did,
So now that was there, and then maybe like my sacrum didn't know quite what to do
Sure.
in that new pattern, so that's how I look at it.
Yeah, I think we did 5 things. Sometimes with the lower windswept pelvis, you'll do up to 6 things. And I think we ended up doing 5 things with you because that's all that you presented with.
Yeah, because my symphysis pubis
was fine.
Yeah.
Okay, so I'll stop filming here.
Oh, I'm sorry, I didn't even know you were filming.
And then I'll see what I find, and then I'll refilm.